Okay, I'll introduce Dr. Steve Ringer. He is our chief of neonatology here at Dartmouth-Hitchcock and is going to be speaking about COVID-19 and the newborn. Thanks, Steve.
Sure, thanks, Maggie. Welcome, everybody. So I'm going to talk as much as possible about COVID-19 and the newborn. You'll hear me say several times, gee, wish we had more data in this regard. And also, I will intersperse things that I think are probably my personal opinion. And I know that there are several people on the call who are very knowledgeable about this as well. So I welcome them to add comments at the end. I don't have any conflicts, and I borrowed some slides from Elizabeth Glazer from the Pediatric AIDS Foundation, who gave a wonderful webinar on this topic as well. So I think try to get through what we know about perinatal infection and the mechanism, and then key in on the issues of management, personal protective equipment, what to do in the DR, and what do you do around and after discharge, and at least understand some of the recommendations for in-hospital care, testing and discharge, and what we think are best practices around postnatal monitoring. Much of this, like is true for the topic as a whole, has been in evolution and flux as we've learned more and more as the crisis has gone on. I just thought it was good to use this slide to remind everyone why we're worrying about this. This does appear to be a disease that has a very high attack rate because of perhaps the ease of transmission, which does appear to be through the usual respiratory droplet mechanism, which includes touching contaminated surfaces, but also importantly, the fact that people are infectious before symptoms, which raises a lot of issues about how do you approach the asymptomatic person in your community, and that they continue to shed for a long time once they have the disease. And the transmission can occur from people who don't have symptoms. At the same time, it's a novel virus, so there's no herd immunity that we are aware of. And then the modern world has facilitated the spread of the disease. So a little bit less often than perhaps a few weeks ago, people at the start of this were saying, well, you know, what are you guys even talking about? Because, you know, newborns and children aren't getting this disease. And it seems with each passing day, we learn how untrue that is. Certainly, physiologically, it makes sense that in utero transmission can occur, but it's been hard to prove this. The early reports from China found no evidence of in utero transmission, and there have been some reports that appeared to show specific IgM and IgG in newborns, but these are tests that are known to be unreliable or faulty. So exactly whether in utero transmission can occur, I think, remains unclear. What does seem to be quite clear is that newborns can acquire the disease in the postnatal period. We were talking before the start about this case report that came out of Texas just perhaps yesterday, about a 3-week-old presenting with a picture of late onset sepsis that turned out to be caused by this virus. So unequivocally, this is an issue that newborns can get, but here's sort of the first admonition. We still need more data. When babies get the disease, These are some of the things that have been cited in a number of papers looking at newborns who are born to women known to have the disease. And you can probably instantly tell that some of these are not related directly to the virus itself, but may in fact be related to the impact of severe maternal disease on the newborn. So asphyxia or death may be more related to that. But there certainly are instances of fever and respiratory distress in the newborn, some of which may be related to the virus, some of it may be related to premature birth. So the admonition when looking at all of this data together is that severe symptoms and outcomes are rare, and most of the issues that arise are not um, associated with the virus itself. A report that's gotten a tremendous amount of play and I think has impacted all of us is this report that came out last week in the New England Journal, looking at 215 pregnant women at New York Presbyterian uh, in the late March, early April, where they were doing universal testing on all women in labor. And I would bet everybody's looked at this already, but about 1.9% of the women had symptoms on admission, and they were all positive for the disease. But the striking result in New York was that 14% of the women who were asymptomatic also tested positive for the disease, or almost 90% of those who were positive were asymptomatic. Some of these women developed symptoms in the postpartum period. So one of the questions I think that has dogged us is, well, this is very concerning because most of the cases are asymptomatic, so you should fear the woman who has no symptoms, um, uh, uh, or in other words, essentially everybody. On the other hand, you know, the report came out of a place where the disease prevalence appears to be much higher than it is in northern New England. But the reason why I have a picture of pie in the sky there is um, we really don't have testing data in northern New England. So we say the prevalence is low, but we don't really know that. So this is an instance where you would think more testing could really guide our practice. These are the recommendations that have been put forward by the American Academy of Pediatrics and others. And they recommend, you know, gowns, gloves, and a procedural mask for women, for encounters with newborns born to women who are positive or under investigation. And the use of an N95 mask or a respirator device when aerosol generating procedures are being done, including positive pressure ventilation, intubation, tracheal suctioning, nasal cannula flow greater than 2 liters, or CPAP, right? So the recommendations around which births to attend are go to the births that you would go to under any circumstances, not based on the maternal COVID status. I think what that prompts is a discussion about, and I would certainly recommend reevaluating whether attendance at planned C-sections at term makes sense now or anytime, as long as people are available nearby. Um, and eh, I think if you're going to attend the birth where the mother is positive or under investigation, then at least in that instance would recommend that people are prepared for aerosol generating procedures. Um, and I think that basically that recommendation is if you're going to, to potentially resuscitate the infant, then you're going to potentially do aerosol generating procedures. Okay. Um, the recommendations are that the infant be separated from a mother who's positive or under investigation because of the real risk of transmission to the newborn, um, both in terms of the baby themselves getting sick and the risk of transmission to the family. But interestingly, the recommendations include, to me, a difficult to completely understand opt-out that, well, if you don't have room to give everybody their own room, keeping the woman and the baby in the same room, but the baby 6 feet apart in an isolette is acceptable. I think that makes sense. But there's also the opt-out of, well, if the mother doesn't want to be separated and has gotten adequately counseled, then that's her choice. I think there were some questions last week that came up about, or in the interim, it came up about the use of breast milk. As far as we know, this virus doesn't get transmitted in the breast milk, so, but the transmission is going to be, if it's going to occur, it's going to occur through close contact with an infected mother. Um, so the recommendation is that the baby be fed express milk by a healthy person. Uh, this is another instance where the mother can choose not to follow uh, tho- those recommendations, which, like many issues in this crisis, raises the question of at what point does public health supersede personal choice? And then testing the baby, the recommendations are if the mother's positive or under investigation, test the baby at 24 hours of age and then repeat at 48 hours. Um, and I would say people have talked about discharging people early, but I think waiting until 24 hours to make sure that normal newborn screening is going to be accurate is highly recommended. And then if the mother's positive or under investigation and the baby is positive, they can be discharged home with close follow-up. If they are negative, they should go home with a healthy caregiver available, separated from the mother, or if not separated, mom to use a mask and hand washing. So plenty of issues still remain. Which births require pediatric attendance, I think may be a silver lining so that it actually teaches us that some births that we're currently attending don't need us there. Uh, how exactly follow-up care at home can be effectively done um, really depends on a case-by-case assessment of what's going on with the family and the available caregivers and how facile you are with phone or other visits. Um, on readmissions, there's no clear guidance. I think if the infant's well with no exposures and has been home with a well negative mother, I would treat that baby as healthy. If the mom is positive or the infant's positive and they need readmission for another reason, admitting them to isolation with PPE makes sense. So uh, just a caveat, almost all the issues arise when the mother is positive or under investigation. Um, hopefully, if testing is available in your institution, the turnaround time is less than the duration of the average labor. So you may eliminate your under investigation group. Um, we still need plenty of more data to know exactly what to do. And this issue of who may have it in your population does mean that there could be a risk from healthy patients, and obviously has impacted our results. Okay, I think the recommendations on what PPE to use and when are based on the best available data. And at your institution, you should consider which births you're really needed at. We're still advocating breast milk given by expression, and testing with the infant. So I hopefully didn't go too far over my time, but I guess we can have questions.
Yeah, no, that was great, Steve. Thank you, as always, for a very thoughtful and thought-provoking presentation. So Kelly and Vicky will have been gathering the questions that came through on the chat. As a reminder, you can see the chat box. It does turn orange if there's a message for that has gone out to everyone or to you personally. And Kelly, again, will be calling on people essentially after notifying them that we'll be using their questioner. Writing their. So Kelly, would you like to take it from here?
Yes, great. Thanks, Maggie.
Mm-hmm.
Alan Picarillo, I want you to unmute because I think you had some things to share that the group would like to hear about.
Yeah, so one of them is just so folks to know that the American Academy of Pediatrics had set up a perinatal COVID registry to hopefully start to answer some of these questions where we have very limited data. The registry, the plan was once it hit 25 babies, they would release a case series analysis. That is supposed to be released tomorrow. So hopefully we'll have some information sometime after lunch tomorrow, at least on the first 25 babies that were born to COVID positive moms in the US and that were entered into the Jacksonville registry. So I don't think it's going to, give the final answer, but at least it will hopefully start telling us what we're doing is safe. And again, it'll be interesting to see some of this. It asks about about 65 different questions about the baby, including testing and where the baby was cared for. So again, hopefully being able to delineate some of the Chinese data, which is a little lacking as we know right now.
Great, thank you. And then I want to turn to Courtney Cook. Courtney, you had a few questions there. So if you want
several questions, and who doesn't in this time? So probably, well, the other ones are more statistically, but probably the most prioritized question for me is if we're sending these moms, these babes home with PUIs or COVID positive moms with just hand and chest hygiene and masking instructions, why are we not doing that from the get-go? That's probably my biggest one, because if I'm going to separate them here in 24 hours, I'm going to send them home together. Why wouldn't I start that education process and modeling from the time of birth versus 24 hours through the discharge process?
Well, I think you could do it. This is Steve. I think you could do it certainly either way. And I certainly agree that you should be anticipating discharge and your education all along. I think one of the differences is that in that 24 hours, a lot of your PUIs are going to convert to negatives. I mean, so you could argue that separating them,
Even a positive COVID mom that's not like severely symptomatic, we're still going to send the baby home with them, and we're still going to educate them on breast and hand hygiene and masking. But so it doesn't make sense to me to separate them in that first 24 hours if they're healthy, with the intent to just discharge them 24 hours later together.
Well, I agree, right? Like I think
the recommendations are conflicting and it's confusing.
Yeah,
the recommendations. We all want to do the right thing.
Yeah, well, the recommendations are confusing, right? I think the intent of the recommendations, and maybe that's because of the way I look at the world, is, well, if you really want to prevent the baby from getting infected, then they should be separated from the mother. But the recommendations turn around almost one sentence later and say, yeah, but if the mother says she doesn't want to do that, then fine. And again, I think if the evidence is that in the most cases, if the baby gets sick, they're not going to be very sick. So you're not the argument would be you're not placing the baby themselves at tremendously high risk, but you are in fact allowing the baby themselves to become a vector for the disease. So I agree with you. They're conflicting, and they make no sense. I suspect what they are is practical and saying, all right, we'll recommend that people separate from their baby, but we don't actually believe they'll do it. So then train them in the other things. But
Right.
So
I
you're
think it's hard
correct.
It's hard to justify taking a baby away in the first 24 hours of life to just discharge them 24 hours with the person we just took them away from.
Yeah.
My other questions were statistical. Of those statistics you just showed, how many of those neonatal deaths had other complications in addition to the COVID positive? So
Oh yeah, I think I'm not. I mean, the real answer is not completely clear. Maybe, but I think when you look at a lot of the reports, it's not COVID that's killing the babies. The link may be, oh, it's a very sick mom who comes in, hypoxemic, and or delivery is precipitated in an emergency situation, right? I mean, if you're doing a perimortem C-section, the risk to the baby is very high. So not unrelated in that respect, but they're not dying of the virus, apparently.
And do you know if there's any information out there in regards to those babes that have been discharged home within the 24 hours with positive moms? How many of those children have actually tested positive in 14 days, or were they separated and chose co-rooming, and what was the disposition?
Yeah, I don't think there's that data, and hopefully this registry that Alan just talked about will give some information about those patients. But some of them, I mean, there certainly are reports of babies turning positive, right? So it shouldn't be a surprise, right? This is a highly communicable disease, and if you're going to be in close interaction with your mother who has the disease, that there's a high chance you're going to get it. So I would bet that the transmission rate to newborns is high. Again, most of them seem to have mild disease, so the risk to the baby themselves may not be that high, but we'll see the data. I mean, it'll be interesting to see the first 25 tomorrow.
And Dr. Piccarello, do you know if that registry is going to be available to the public?
Yeah, Courtney. So it's going to be posted on the Academy of Pediatrics Society for Perinatal Medicine. So I don't know if there's a password protected, but again, it's going to be public data. So I assume it'll be published somewhere. So if you don't see a copy or can't find it, just shoot me an email and I'll forward it on to you.
I know how to find you.
That means she knows where you live.
Great, thank you. And Sharon Vuplo, do you have the ability to ask a question verbally this week?
Yes, I do. Are you all able to hear me?
Yes, great.
Okay, great. First of all, thank you, Dr. Ringer, for that great presentation. So I had a question, and I brought this up in a call last week. But again, there seems to be some there seems to be a lacking clarity in terms of what the CDC recently put out in guidelines about how to approach a mom with pending testing or a mom who has not been tested. So at our institution, all mothers coming in to labor with symptoms that fit the criteria of COVID will be tested, so that's a good thing. But we are not necessarily considering the baby to be a PUI or doing testing in the baby. So again, I think the guidelines there are stemming from what was very vaguely put in the CDC guidelines. So you essentially answered that question to me. It seems that you are recommending AAP's recommendation of approaching such a newborn as a PUI, testing the mom. You even suggested that we should not necessarily discharge the patient before having testing results. So you certainly answered a lot of my questions already.
So let me be clear. I mean, again, this is an area where the recommendations, even from the AAP, are a little either unclear or wishy-washy, right? So the recommendations are test at 24 hours, test again at 48 hours. But if they go home, don't worry about the 48-hour test, even though that's probably the more reliable test. My admonition about keeping them for 24 hours is I understand people have wanted to discharge the mother, the well mother and baby sooner than 24 hours. And I think, you know, there's a lot of testing that we do that requires waiting to 24 hours that will be lost or mucked up if you're, you know, so congenital heart disease screening, you know, you're going to get more false positives if you screen before 24 hours, and similarly state metabolic screening. So I don't think it's worth it to send them home and then make them come back. But that's a matter of personal opinion.
Okay. I also just wanted to bring to everyone's attention that I think yesterday or the day before, there was a case report published out of Lima, Peru, with authors from a medical center in Texas that report a mom who presented in labor at 33 weeks gestation, had a very severe illness, ended up having to be intubated, and baby had a RT-PCR for COVID-19 at 16 hours of life, which actually tested positive. So in the case report, they don't comment on if cord blood was sent or placenta was looked at, but I just thought that was a very interesting case report that just came out. Obviously, this is just one report.
It's a good point, though, because as I said, it certainly appears that physiologically in utero transmission can occur. It just hasn't been reported. So this may be the first report.
All right. Well, thank you. Let me say, Kelly, do you want to do one more quick question or move to the case?
I think we have a really quick question. I'm going to ask Viking Hedberg to unmute, introduce yourself, and ask your question, please.
Hi guys, Viking Hedberg, Concord Hospital. Sort of looking at this data, it seems like the risk of a fresh newborn of having COVID in the respiratory tract seems very low. And I'm wondering, is there any data that says resuscitation is a risky endeavor? Because if the virus isn't in the respiratory tract, it shouldn't be at risk. Although that mentioned from the report from Lima was that potentially, I guess it could be. But I don't know if there's any data that can help guide that. My concern really is with limited PPE, we're having pediatricians and the newborn caregivers in at-risk moms using high-level PPE, and we're not necessarily having nursing who's attending the mom during deliveries if they're not known, quote, at risk to be using that PPE. And it seems like that would be the higher risk situation than actually the newborn resuscitation.
Thanks, Viking. A great question. I mean, I think, first of all, I'll answer the second part first. Gee, we ought to be consistent, right? Like, you know, if you're worried about them, then you're worried about them. And if you're not worried about them, then you're not. So I certainly agree that everybody should be playing by the same rules. I think, again, the wild card is exactly the one that you mentioned. You know, is there in utero transmission, and therefore the baby is potentially you know, if they're infected, you know, is resuscitation a risk? And at this point, I think the answer is we don't really know, but it's possible. So do you want to take a chance? So then it becomes a measure of at what, you know, what's your threshold for pulling out all the stops on PPE?
Yeah, I appreciate it. I think that makes sense. And unfortunately, the issue is we don't know the answer to that question.
Yeah, that's exactly.
We have guidelines based on guidelines.
Yeah.
So thank you.
All right. Well, thanks everybody for that discussion.